Well, I very much want to thank everybody for coming to the High IQ Community Forum today. This is a very, exciting presentation on improving transitions of care for heart failure with a deep dive in CODE-HF. As many of you know, the UMKC's Institute for Innovations in Healthcare Quality is really trying to bring together multiple stakeholders to collaborate on improving the value of healthcare in our region. And, heart failure has been a huge challenge across the country, in large part stimulated by the fact that Medicare created a hospital readmission reduction program, an effort to risk adjust 30-day readmissions. And as a part of that, there's been a lot of effort and focus on trying to figure out how to improve the transitions of care. We, have launched several initiatives that different hospitals can pick which ones they want to do. None of them deal with the sort of transition of care that hospitals already have in place, risk stratifying their patients to identify who should have different intensities of follow-up. But, one pilot that we haven't yet introduced more broadly is trying to figure out how to do a warm handoff and link between the payers who have disease management programs and the hospitals who are caring for the patients to smooth that transition of care. A second has been led by the Mid-America Regional Council on trying to address social determinants of health and reduce inequities. And then a fourth one is working with the American Heart Association on Implement-HF to optimize guideline-directed therapy. But really the third and sort of the key one that we're focusing on today is CODE-HF. It's a strategy to try and risk stratify patients in the emergency room to see who really needs to be admitted and who doesn't. And towards that end, we were deeply inspired by some work that Doug Lee, a cardiologist and endowed chair up in Toronto, Canada, had done in trying to build the risk models. And we'll go into them a little bit more deeply later to figure out, who was presenting to the ED, was at high risk for sort of dying in the short future, for whom you'd really want to be aggressive about admitting and managing, and who, is at lower risk and might be safely managed as an outpatient and prevent a readmission if they had come in within the prior 30 days. And that was the CODE-HF program. And, today, what we thought we would do was, really do a much deeper dive in this program. And it's sort of in the spirit of transparency, quality improvement. There's going to be some dirty laundry here, some challenges that we've worked with, but we want to collectively learn from those. And so the way that we have organized today's session is to have Doug, who literally just 2 weeks ago gave a late-breaking clinical trial and a simultaneous publication in the New England Journal of Medicine about the work that he's done up in Ontario to really define the clinical outcomes associated with these kinds of risk stratification strategies. And then I'm going to describe the journey of CODE-HF at St. Luke's, how it got developed and formed, what our initial data was, and then how it's rolled out. And, as we share this, there are challenges in adoption and sustaining the intervention. And so Danielle Olds and Stacy Farr and Kate Villain have done a series of qualitative interviews working with the providers and multiple stakeholders at St. Luke's Hospital to better understand what worked, what didn't, what were the facilitators, what were the barriers, how can we best inform other hospitals thinking to roll this out in what we've learned so that you could have a more successful and sustained launch than we have had. And then to have Ken Marshall and Janek Patel, who are leading this effort at KU, describe sort of their early experiences with it. And they have literally just gotten going. And so that's the way we've laid out today. We'll have discussion briefly after each of the presentations, but more in-depth and detailed discussions will happen at the end for those who are available. And I'd really like to sort of kick this off by turning the podium, if you will, over to Doug Lee. I've known Doug for 15, 20 years. He was in junior high school when we first met. And it's been really remarkable to watch his career. He's an outcomes researcher trained at ISIS, which is sort of the premier cardiovascular health services research program that really got launched with JAK2. But they have a number of really extraordinary scholars. There's a lot of creativity that goes on up there. They have unbelievable access to data to really understand and study, the care and outcomes in Ontario. And I think in many ways, at least as it relates to this program, have been a leading light for us. We've been very inspired by their work. We adopted it long before they had evidence proving that it worked, because in large part, the logic and the methods and the rigor was so sound that it would violate a lot of my philosophical beliefs if it had failed. And so, Doug, it's really nice of you to take the time to share with us what you presented at AHA and to update us on sort of what you found when you formally tested this kind of risk stratification program. So thank you very, very much for joining us.
Okay, thank you very much, John. That's really kind words. And we've truly admired the work that you've done and the leadership that you've showed internationally, and starting out in Kansas City, but kind of having such great impact internationally. So, we kind of echo a lot of the work that you guys have done. So I'm going to just share my slides.
May I interrupt just briefly? Everyone on the line, can you mute yourselves? Please mute yourselves.
Why can I not hear?
Hello, please mute.
Okay.
Thank you.
Okay, fabulous. Thank you very much, Patricia. So I also, really kind of to your credit, you've been kind of really spearheaded some of the adoption early on, even before the trial results came out, and that's quite visionary on your behalf and the group there. It's a real pleasure for me to share some of the results with you on the COACH trial. This is the presentation that we gave at the American Heart Association meeting, and so for folks who were there, my apologies if the slides look similar. But I haven't had too much time to change things around in about a week and a half. So, it's a real pleasure to share this with you. So I'm just going to try to advance my slide. So patients who, as you know, when patients come to the emergency department, they are often hospitalized, and we, as clinicians, have typically relied on clinical judgment to decide whether to admit or discharge our patients, what we call the eyeball prognostication. And our eyeballs as clinicians are pretty good, but there are some high-risk patients who get discharged home inadvertently. And we've shown in Ontario that when those patients go home, they actually experience a high rate of death and other adverse outcomes. And in some cases, the lower risk patients are hospitalized and could be discharged home potentially and followed in ambulatory care. And so that's where we realized that one of the barriers to early discharge of patients from hospital, from the emergency department and from the hospital, is risk stratification. And that led to us wanting to develop the EMERGE score, and the lack of access to specialized rapid ambulatory transitional care after discharge. We spoke to the EMERGE docs and said, hey, some of these patients are low risk. Why don't you discharge them home instead of admitting them? And they said, well, we send them home and then they never get to see anybody. and they end up back in the emergency department. So we just admit them. And so it came pretty clear to us that what we needed to do was to provide a receptor for patients who are discharged home that could provide high quality care. So the objective of the trial was to determine if a strategy of using the eMERGE 30ST, this is a modification of the score that includes the 7-day risk score that's currently available with a 30-day risk model, which has been validated prospectively, and using it in the emergency department, combined with standard rapid transitional follow-up care in the clinic, and to determine if this improves clinical outcomes. So our trial, the COACH trial, was a stepwise cluster randomized trial. Essentially, we had hospitals that were randomized in different steps, and the hospitals were blinded to the allocation sequence, so they didn't know when they would be randomized. All of that randomization was done centrally, and then we only told them 4 months before that they were gonna launch that they're up in 4 months' time. And so in that 4 months, they had to scramble to find the nurse to help run the clinic, to organize their IT systems, to find a location for the clinic, and to organize the referral process so that it'd be seamless. And so you know, all of the studies did this fairly quickly. They had the help of an implementation science team who helped them, and we also had local champions at every hospital to help facilitate the process, and also we tried to involve the administrators at every hospital as well. So this was we had pretty broad criteria for the trial. Was pragmatic. Anyone over the age of 18 years or older who presented to the emergency department with acute heart failure, based on a clinical diagnosis by the physicians, a diagnosis of heart failure on the ED face sheet, also meeting the Framingham criteria, were eligible. We excluded patients who did not have heart failure based on using their BNP results, those who were palliative, because those patients were not eligible for a score calculation, and those with end-stage renal disease. And we also had a few criteria that where it was pretty clear that the patients would have difficulty attending outpatient clinical visits. So we excluded those patients up front, and I'll just show you what those exclusion criteria were. And then we required patients to have a health card number. And so in Ontario, a health card number is a single number that's given to every person who's eligible for health services in Ontario. And using that single number, we can then link multiple databases, hospitalizations, emergency visits, physician visits, whether they are, their mortality status. And so that's a key number that everyone needed to have. And we also went through, we made a lot of effort to get a waiver of informed consent. So we thought it would be impracticable to consent people in the emergency department and ask them if they want to participate in the trial. And so every IRB allowed us to have a waiver of informed consent so we could recruit patients without requiring them to fill out a consent form. And also allowed us to include patients regardless of language or other barriers to trial participation. So the intervention really had 3 components. The first is this risk algorithm is shown here on the left. And so this risk algorithm is a composite of a 7-day risk score shown on the x-axis here, and a 30-day risk probability shown on the y-axis. And we kind of have this plot here. And if you, based on the patient's clinical characteristics, every patient has an XY coordinate. And if it lands them in the high risk zone, in the red zone, that means they're high risk and should be admitted. If they're in the green zone, it means that they're at low risk at 7 days and 30 days and could potentially be discharged. And we encourage discharge. And then the yellow zone or the orange zone are patients who are intermediate risk. We actually encouraged clinicians to use their clinical judgment there. And if they're low intermediate risk, that they could potentially be discharged. If they're high intermediate risk, that they should probably be admitted. The second intervention was the rapid ambulatory clinic or the rapid heart failure clinic. And this was a transitional care clinic that only operates for 30 days after hospital separation. So because it was only staffed by one nurse and ran 3 or 4 times a week in the afternoon, it couldn't keep accruing more patients. And so it was a transitional care clinic that only provided care for 30 days. After that 30-day period, the care was handed off. The baton was handed over to either a primary care doctor, a cardiologist or internal medicine specialist in the community, or a multidisciplinary heart failure clinic. And during those 30 days in the rapid clinic, patients basically got all of the care that they would get in the hospital ward as an outpatient. So all the blood tests, all the medication up titration, all the diagnostic investigations, they were ordered through by the nurse clinician and the cardiologist who was supervising the rapid heart failure clinic. They got all of that care as an outpatient. And so we kind of liken it to, in the hospital, care comes to the patient. In the rapid heart failure clinic, patients come to get their care to the hospital. And again, the patients who are lower risk, we encourage discharge either directly from the emergency department or discharge after a short length of stay. In those who are higher risk, we strongly recommended hospitalization. In those who are intermediate risk, we recommended that they could be discharged or admitted. And in all cases of the low risk or intermediate risk patients, if physicians were unsure of whether to discharge or not, they could admit them for a short stay of less than 3 days. And then after that, if they're discharged early, then they were eligible for the rapid heart failure clinic. So there was a kind of a set of rules that were required to be eligible. The third part of the intervention, which we really, was a key part of the intervention, was an implementation science team who was, really actively involved in helping to implement this. And we didn't have a lot of time to give them credit, but they were an important part of the team. So we had 2 co-primary outcomes. We looked at all-cause death or cardiovascular hospitalization. And the cardiovascular hospitalization was chosen because it includes a broad range of cardiac outcomes, but also it was amenable to modification by intervention, we thought, because short hospital length of stay were associated with an increase in cardiovascular hospitalizations. And so we thought this is where the money was, and we should go there. And we had 2 primary outcomes, 30-day outcomes and a 20-day outcome. We also looked at the individual components, subcomponents as secondary outcomes, as well as shown here. And all of the outcomes were determined passively. So we have a long history of using administrative databases to do outcomes research in Ontario. We found that it's quite, there have been a lot of validation studies and it's quite accurate. And so, we decided to use that to determine the outcomes of our patients, so that patients didn't actually need to be contacted by a research coordinator. We could just simply query the database once all the data was available to determine outcomes. So we had a sample size estimate of around 8,700 patients that we would need to detect about a 10% relative reduction in outcome. And then the trial ended recruitment in January 2019, and then we began statistical analysis in December 2021. Because this is a pragmatic trial where we were collecting data on patients, there was actually, we had to send chart abstractors to the hospitals to collect that data, and that took some time. And then the data linkages needed to be made available. And so there was a little delay there, but we ultimately started our statistical analysis in December 2021. We used the Cox proportional hazards model for time to event analysis and logistic regression for binary outcomes. And then we did what's typically done in step-wedge trials, which is adjusting for step or period effects, and then the hospital teaching status. the heart failure patient volume, and also clustering within hospitals. And then for the logistic regression, we had a special small sample correction that's required for use for small samples because this is a smaller trial. So the flow of our patients in the trial are shown here. We had over 10,500 patients whose unique patients who we were able to examine. And then we had some exclusions here. Those were palliative, those who actually didn't have heart failure according to our criteria, those who did not have health card numbers that would make them linkable. And then we excluded patients who, we really felt it wouldn't be, it would be more of a burden for them to actually come back to clinic multiple times because they had limited mobility, because they had dementia, because they were nursing home residents or had no fixed address. And so these people were excluded. And so we had 2480 patients in the intervention arm and 2972 in the control arm. These are the baseline characteristics of the trial. We had the median age of 78 years, 45% were women. So a slightly older population than what we would expect from a kind of a typical industry-funded trial of a drug, for example. And this is because we're looking at real-world patients, the type of patients that you would see in your clinic and in your emergency department and in ours. And when we look at the medications, the rates look a little lower compared to what you would expect from an industry, from the trial of HFrEF, for example, because a substantial proportion of these patients had HFpEF or HF middle range ejection fraction. And some of these were new heart failure patients who a first-time diagnosis, and so they weren't on these drugs before. And just looking at the processes of care, so this is what happened to the patients in terms of their early or emergency hospital discharge. So as you'll recall, we suggested discharging our low-risk patients more. That actually didn't happen. We actually had a similar percentage of patients who were low risk who were discharged early in the control and active intervention arm. In the high-risk group, we recommended admitting the high-risk patients, and that did happen. So there were fewer discharges, early discharges of high-risk patients in the active intervention arm compared to control. And where we did see a slight increase in discharges were the intermediate risk patients. And actually, there were more intermediate risk patients who were discharged with the intervention than the control. Where we did see, this is now data which I didn't show at the meeting on physician follow-up. And so, one of the other elements of the intervention, which I didn't mention earlier, is that when patients were discharged early, low risk or intermediate risk patients, we tried to see them within 72 hours. There are 3 working days. That didn't happen in all cases, but we did our best to try to see them within 3 days of hospital separation in the rapid clinic. If we contacted the patients and determined if they had a usual provider of care, like a usual cardiologist or internist, and if they could see the patient within 72 hours, their care was directed to them as opposed to seeing them in the rapid clinic. But we tried to get them seen within 3 days. And on the left side here are the follow-up, the median time to follow-up physician visits with any physician. So that's a cardiologist, internist, or a primary care doctor in the control and intervention arms. There wasn't really, little difference between in the 2 groups in the follow-up with any physician. But if you look on the right, there was a difference, significant difference with follow-up by a cardiologist or internal medicine specialist. And the median time to being seen by a cardiologist or internist in the low-risk group was about 12 days in the control group, and that dropped to about 6 days in the with active intervention. In the intermediate risk group, the median time to being seen by cardiologist or internist was about 9 to 10 days, and that dropped to about 7 days. And in the high risk group, there was also a slight drop as well. So the bottom line is that there was faster follow-up by a cardiologist or internist, especially in the low risk group. So these are the primary outcomes of the trial. The inset shows the unadjusted outcomes for the control group in red and the intervention group in yellow. There was some separation of the curves there fairly early on. And then in the larger plot is shown the adjusted final results for 30-day primary outcomes. And there was about a 12% relative risk reduction of the primary outcome within 30 days. P-value was 0.036. Up to 20-month follow-up, and we felt that it's important to look at a longer-term follow-up because we wanted to see if the gains that we had at 30 days continued. And we did in fact see a significant difference, albeit attenuated out to 20 months, about 5% reduction with a p-value of 0.007 with the intervention. Our secondary outcomes of cardiovascular hospitalization are shown here, and there was a significant reduction in cardiovascular hospitalizations, about 16% relative risk reduction with the intervention, and a significant p-value of 0.001. And heart failure hospitalizations exhibit a similar pattern, the hazard ratio of 0.80 in favor of the intervention. There was no difference in mortality over long-term follow-up over 20 months. So in conclusion, patients with acute heart failure presenting to the emergency department, we found that using the eMERGE-30ST, which is a point-of-care tool to support clinical decision-making about 7-day and 30-day outcomes, coupled with rapid outpatient clinic follow-up, reduced the risk of death or cardiovascular hospitalizations within 30 days and 20 months. And implementation of this approach could lead to potentially to early discharges from the hospital or emergency department, as well as improved patient outcomes. I would like to thank our co-investigators of the trial who were really seminal in kind of all aspects. We had a really involved, my co-investigator Heather Ross, as well as the steering committee. And we had some very involved clinical site leads. These are the champions from each of the sites. And in some hospitals, we had more than one champion. And they were really key. I mean, this was not a trial. This is where, we had a lot of funding to pay the site leads for, recruitment of patients in the trial. We had basically kind of a shoestring budget. And so, a lot of the work that they did was, because they kind of thought this was the right thing to do. And thanks to our funders, the Ontario Sports Support Unit and the Ted Rogers Center for their contributions to the work to this study. And so, so this is our last slide. So it was published in the New England Journal of Medicine, and it's a simultaneous publication. And I think that's the last slide I have. Thank you.
Thank you very much. That was terrific. I have a lot of questions. I want to open it up to others to ask questions briefly, but I did want to just take the moderator's prerogative and say, so knowing what you know now, you've implemented this at a dozen centers in Ontario, how would you roll this out? What would you focus on? Do you think that we obviously focused on early discharge. You focused on 30-day readmissions. We didn't anticipate we would quite have the data or the ability to quantify that. There was a big impact on 30-day readmissions, which is very meaningful to us. What have you learned that if you were going to sort of support or encourage this in routine clinical care, would you share with us?
Yeah, I mean that's such a huge question, I can only tell you what I've learned. I'm not sure it's certainly not a solution to the problems that face heart failure patients, but one thing that we learned was that there's external kind of pressures and external forces to try to implement change. And then there's internal, champions who implement change. We worked hard to get, our internal champions, who really helped to drive the intervention at the sites. And so, I think that's the key. We found that there's a lot of there's a great need for risk stratification, I think risk stratification has faced some challenges as well, because in terms of its ultimate value in affecting changes in outcomes. And so, I think that's one of the things that we learned through this process, is that when we have decision support tools, it's so critical to be able to try to put those to the test and show that they have an impact, in either prospectively in a prospective study, or in a clinical trial, or in a pre-post quality intervention, quality improvement study. Just kind of demonstrating that there's an impact using data. So I think those are the two main things, John. I mean, it is, there's just so much room for improvement in heart failure, that starting anywhere really, I think, will be helpful.
Great. Well, you graciously offered to stay through, Q&A, and I hope we can stay on time, because I'd love to get your insights into some of the work we're going to share with you as we get going. And so your expertise, and again, thank you very much. Are you all seeing my slides okay? I hope so. Well, yeah. I wanted to describe the, sort of how we came up with CODE-HF and what the journey has been like at St. Luke's Health System. And so, back in 2015, St. Luke's launched something called its Innovation Center. And, this was an idea. I mean, a lot of times in the US, the C-suite hospitals will go to big conferences, they'll hear about some new innovation care, they'll come back and say, well, we should do this. But, we had the idea that, look, it's very important to, if you want to affect change, to have change be emanating and coming from within. So if you could inspire the staff, and there's literally nobody who works at a hospital who doesn't say to themselves 2 or 3 times a week, boy, if only we did things this way, they would be better. We thought, well, if we could harness those ideas and then really empower those who had the best, ideas that we thought would really improve the value of care in our health system, we would overcome some of this clinical champion challenge and barrier and really be able to lead to an effective culture of innovation here at St. Luke's. And so this was a center that was designed to solicit ideas from anyone, from janitors to the chief of neurosurgery. What did they think could be done better at St. Luke's? And it was competitive, and we would fund 2 projects a year with the staff to help implement those. And so it was a big commitment by the health system. And so in this first round, Gary Gaddis, who was an endowed chair in emergency medicine, proposed the idea of triaging heart failure patients in the emergency room. And, ultimately that wasn't selected, but and Gary went on to take a position at WashU, but Ali Scholes, really liked the idea. She revised, she resubmitted, and it got approved for funding. And so once approved, we had the project management office help us coordinate a lot of meetings with different stakeholders, nursing, cardiology, administration, to really help, design the program. And that's essentially how our journey began. And, it came from the idea that there is this carousel of readmission that happens in heart failure. And while we can intervene at different ways to prevent readmission, one strategy would be to risk stratify patients who have a history of heart failure and who are short of breath or have swelling and volume overload to decide, do they really need to be admitted or not? Because that's a difficult decision for the ED to make. And when we looked at our data in 2016, what we found was tremendous variability. So this is each of the 41 emergency room physicians. This is all the patients they saw in 2015 for heart failure. So, some saw 100, some saw 80, whatever. And, here's a doctor, here's a doctor who is sending about 1 out of 3 patients home. And at the other end is a doctor who every single patient he or she saw with a history of heart failure and shortness of breath, they admitted. And so that's a lot of variation. And it varies a lot by doctors. I mean, it's almost random who's on and who the attending is when a patient shows up. So we thought that this really called for a more standardized assessment and strategy to decide who to admit and who not to admit. And, the clinical logic was, well, why would you admit a patient with heart failure? Well, you would admit them to prevent death because they're critically ill. You would want to make them feel better with, diuretics, blood pressure control, optimizing their medicines. You could determine why their heart failure was worse. Did they have a heart attack? Was there something else going on? And if this could all be done as an outpatient, then maybe you don't have to admit them. So if they're at low risk for dying, if they feel better in the emergency room, if it's obvious why they are worse, like they didn't take their medicines for the last 2 weeks, and you could get early outpatient care, then it seemed like this would be the right way to manage those patients. And the critical sort of feature, I mean, yes, you have to ask the patient if they feel better and all of that if they want to go home, but ultimately the biggest challenge in this logic was figuring out, is this patient likely to die in the next week or two, or are they not? And so this is how we became aware of Doug's model. This was predicting the likelihood of a patient dying in the next week. And this is the distribution. So the proportion of patients and their 7-day mortalities on the y-axis. And so what we said in discussion with our cardiologist was, if they had a 1% chance or less of dying, and they felt better in the ER and we had good follow-up, it would probably be safe to send them home. So we wanted to establish a acceptable standard in the health system. And we thought a 1 in 100 was pretty good. And that would apply to about 50% of the patients that were in the original study that Doug led. So with that, we decided to develop this CODE-HF pathway. So patients come in with a history of heart failure, they're short of breath, they got volume overload. We make the diagnosis, we give them Lasix, and then we risk stratify them. And if they're greater than 1% chance of dying in the next week, we would admit them. That's our standard of care threshold. But if it's less than 1%, we would see, are they feeling better with the Lasix? Do we understand why their heart failure got worse? If they feel better, if they don't feel better, then we admit them. If they do feel better, then we talk with them about, do you want to go home or not? We try and make a sort of shared decision. And if we as the physicians or the patient doesn't want to go home, then they get admitted. Otherwise, we provide some education, and we had a way to call to get them into cardiology follow-up within a week. And so this was the pathway. And so we rolled it out under Ali's leadership, and the results were published. But just to summarize them briefly, when the CODE-HF pathway was used, then we were about a third more likely to send patients out of the emergency room. And, we were reassured that we were sending the right patients out of the emergency room, because when patients were sent out of the emergency room without the CODE-HF pathway being done, they were 40% more likely to be coming back within 30 days than if they went on the pathway. And this gets to Doug's point and concern that there are high-risk patients that inadvertently get sent home with usual care, and that's not good. It was substantially higher likelihood when usual care was used that patients would come back within a month of leaving the emergency room. We reduced the number of, in Canada, the funding's a little different, but when we admit somebody for less than 48 hours in the US, we only bill as an outpatient visit. So we really don't get paid for the extra, day and a half, 2 days that they spend in the hospital. And so by, preferentially admitting the higher risk patients and sending home the lower risk patients, we had fewer short stay admissions. And that was financially good for the hospital and good for the patients and good for the staff, because why, spend a night or two in the hospital when you could be cared safely at home? Importantly, when we rolled this out, there was a lot of concern that the ER is a very busy, a very stressful place, and that it would take, this complex algorithm would take more time. But in reality, it was almost an hour shorter door in to door out in the ED. So it was 48 minutes less time in the ED, which we thought was really, really good. And then, like Doug showed, we were able to improve the proportion of patients who were able to be seen by cardiology within 7 days, which was also good. And so this all looks like amazing data. In fact, I thought it was amazing data, better than we had anticipated or hoped. And then we looked at our utilization, and it turns out that the CODE-HF pathway was done in only about 1 out of 6 patients, 1 out of 7 patients. And, that's not a very good implementation. And when we look by provider, there was enormous variability. There were a lot of the doctors who basically never used it, and just a few doctors who used it a lot. And so this was a real challenge for us. And so we went back to the drawing board. We worked with Ali Scholes. We worked with nursing in the ED. And, we tried to come up with strategies to improve adoption. We met with the ED staff. We met with cardiology to ensure that they were supportive of this. And that not only included the heart failure doctors, but presenting to the entire cardiology group. And we decided to create a standing order. The ED is a very busy place. There's, one day you might have 3 heart failure patients and you might not have another heart failure patient in 2 weeks. And it's hard to remember to launch this new CODE-HF pathway. So we thought, well, why don't we create a standing order? You've got the nurses who are looking at the medical record. They realize they have heart failure. The patient standing before them saying they're short of breath. If they could launch a standing order, it's hard to get a standing order approved, that could really, really help. And so, we met with administration, we got real good support from nursing, and we ultimately got the standing order approved. And then we were asked to re-examine our data by the ED doc as they were considering whether it was useful to continue the standing order or not in 2022. And so this is an updated sort of results from 2020 to 2022. And, over that time, from the first quarter of 2020 to the second quarter of 2022, there were 4,500 patients who had a history of heart failure and complained of shortness of breath, edema, fatigue, or weight gain. And, we sort of, with the standing order, went from 12% to 41% launching the CODE-HF pathway, which is a huge improvement. But, just because it was launched doesn't mean that people actually calculated the score or used it. It was just launched. And in fact, only 14% of the time was the eMERGE score actually calculated. And, there was no score, it wasn't done in 27%. So, it was sort of sobering. And like the work we saw before, there was great variability across hospitals in whether they used or didn't use the score. There was great variability across provider in whether, they used the score or not. And, when we looked at when the score was used and when it was not, and looked at what happened, when the Code HF score was not, the Code HF program was not used, 84% of the patients were admitted. When it was used and they were high risk, we admitted 75%, but we only admitted 50% of the low risk patients. So, it was valuable, I still think, to admitting fewer low risk patients when the Code HF score was used. And similarly, the time in the ED was markedly shorter, again, about 45 minutes less time in the emergency room for the low risk patients where the Code HF score was run than when it wasn't, or whether they were high risk. And so our insights from the updated analyses were that the execution of Code HF is still suboptimal. It ran at 12% 2018. Now it's up to 14%. The inclusion as a standing order did markedly increase its acceleration by 3.5-fold, but the ED teams completed the score less than a third of the times when it was activated. There's a lot of variability by sites and by individual providers, but when it's used, we think we have more safe discharges than when it's not used. It did reduce time by 48 minutes for low risk patients versus when it was not used. And we still think it could be an ideal triage for hospital at home, a new effort that we're starting to embark on to provide sort of higher level care for slightly higher risk patients. So you wouldn't do it for all patients, but if you had some trepidation about sending a patient home who had a near 1% risk of dying in the next week, you could activate hospital at home to provide higher quality, more intense care that would normally be done if you sent them home without it. So I'm going to stop there. That's sort of the overview of sort of what our journey has been like at St. Luke's. If there are any quick questions, I would be happy to address those. Otherwise, I'd like to turn it over to Danielle, Stacy, and Kate to help provide some insight into what they learned, some of the facilitators and barriers might have been. So if there are any questions, please speak up. Otherwise, off to you guys.
Hey, Dr. Spertus, can you hear me okay?
I sure can.
Yeah, I just had a couple questions on how often you guys were giving feedback to the ED physicians on their own metrics of how often they were using the score, and what feedback you got from the physician group, the ED physician group, if you had any insight about why the low utilizers were not utilizing the score.
Yeah, so I think that you've given the perfect tee up to Stacy, Danielle, and Kate. And so I don't want to rain on you guys' parade. I'm happy to answer that, but if this is going to be what you're going to focus on, then I think I should not answer.
Yeah, I think we'll give ours, and then I think that'll be great. We can discuss it in more depth a little later.
But the short answer is that we did create feedback reports. We didn't. We had some mistakes early on. The reports took a long time with our IT to build those reports. And even when they were built and optimized, we had some trouble getting a clinical champion to really share that with the group and use that as a foundation for driving change. But I think those reports are very, very important.
Awesome. Thank you.
All right. Well, thank you. So my name is Stacy Farr, and I'm here with my colleagues, Dr. Danielle Olds and Kate Mullane, and we're going to talk about kind of the perspectives on implementing the emergency department decision aid for heart failure that you just heard about from Dr. Spertus. So we're going to cover just a little bit of introduction methods, the results, conclusion, and summary, and some of our next steps. So some of this may be a little bit of repeat, but I think that's always a little bit helpful. So to let you all know a little background, the hospital readmission reduction program, or HRRP, which we discussed, was established through a provision of the ACA, where Medicare was allowed to reduce payments to acute care hospitals with high readmission rates for those in traditional Medicare. And I think what's interesting or important to note is that with HRRP, this is for hospitals are penalized for when they're exceeding the national average. So they're basically, they get reductions in all their payments, even if it's just readmissions for specific conditions. So this is across all of their payments, Medicare payments, and CMS is the primary payer for nearly most acute care hospitals. And this is up to 3% of all their Medicare payments. And heart failure is one of those conditions. And so extraordinarily important, and hospitals are obviously strongly incentivized to reduce their heart failure readmissions because of this. A lot of common strategies, as you heard from Dr. Spertus, are risk stratifying patients prior to discharge for early intensive follow-up or disease management. And the alternative that was described is really thinking about risk stratifying in the ED to see who can be safely discharged home. And as we saw also in Dr. Spertus' presentation, there's high provider and hospital variability in discharge rates from EDs for heart failure. And so that's another reason that there's great opportunity for more to streamline and make things reduce variability in care. And so with our, I just lose my share screen. Okay.
Yeah, we lost you.
Okay.
Now it's coming back.
Okay, sorry about that. Not my computer, I'm learning. Okay, so with that, we launched, CODE-HF, which is a standardized care path developed, implemented to better identify patients for inpatient admission versus discharge. And as you just heard from Dr. Spertus, this was done as a pilot in 2018 and 19 and is in the 4 hospital system, healthcare system here, St. Luke's. And despite some of these positive patient unit and hospital level outcomes that you just heard about, there was a lot of low adoption. And so our team then, and this is just the article from the pilot here. And so our team worked through the Healthcare Institute for Innovations and Quality, the network of hospitals and other stakeholders to collaborate, improving healthcare quality, value, and equity. And since CODE-HF was one of these innovations that it was embraced for the hospitals for implementation, we undertook a qualitative study to really understand the implementation barriers and facilitators within this 4-hospital healthcare system before we scaled this and spread it to others. And so we developed semi-structured interview guides. These were modified from the Tailored Implementation for Chronic Diseases, which is a determinants assessment in implementation science. So very high level, this is a picture of just part of the TICD, where the TICD has 57 different determinants, which determinants are essentially barriers or facilitators, right? So it has 57 different determinants of practice, and they're grouped into 7 different domains. So we reviewed this and tailored this specifically to those that would be relevant for CODE-HF. And those domains are guideline factors, individual health professional factors, patient factors, professional interactions, incentives and resources, capacity for organizational change, and social, political, and legal factors. And so then from the fall of 2021 through fall of 2022, our team of researchers developed, using those interview guides, did semi-structured interviews with 23 individuals. We did snowball sampling to identify the right participants and did that until we achieved data saturation. We then used Deduce as our primary software, where we did inductive coding. Again, this is informed a priori by the TICD as the general domains, but this was very much taking what came from the qualitative data, turning that into codes inductively, and then doing thematic analysis with our teams in a group setting. And from there, we are currently in the middle of preparing for member checking to check some of these analyses with the stakeholders we interviewed. And from here, I'm going to turn it over to my colleague to talk about our results. Here's Dr. Olds.
All right, so for the results, I'm going to take you through 6 themes, and each of them had some supporting quotes to really show you the story. So the first theme is exceptions to the traditional evidence-based practice adoption process, along with turnover in ED physician champions, led to less buy-in and engagement. So for this theme, it's important to know, as John mentioned, that this project went through the Innovation Center, which is a slightly different process than how most of the EBP practices are implemented. And then, as John mentioned, the ED physician champion ended up leaving the practice, and then there was another ED physician champion who ended up taking a different role, and there's been a couple more ED champions since then. But throughout this turnover of ED physician champions, the researcher and the research team were really consistent and sort of the consistent faces of the intervention. So this is a quote from a hospital administrator. I think that part of the perception is that it's very odd that the push to abide by this comes from research and not from practicing clinicians. It feels like it is coming from a non-clinical department. And then this quote comes from a quality improvement staff member who said, the ED is one of those places where you have to have multiple ED champions believe in what they're trying to do. And if you want to try to change something, there better be a really, really good reason that they believe in it. And this really emphasizes the culture of the ED physician practice is that they tend to have a group of champions who are viewed as informal leaders who achieve group consensus rather than a succession of individual champions. So theme 2 is initial and ongoing education was inadequate and did not emphasize the nature of the tool as another decision aid for ED clinicians. Throughout our interviews, physicians and nurses brought up the need for ongoing education because of turnover in staff, especially during COVID. But for the quotes, I want to highlight the need for education because of misunderstandings about the tool. So this is a quote from a cardiologist. They know that heart failure is a leading diagnosis, obviously for admission, so there's not resistance to incorporating a particular tool if it helps them with risk assessment. I mean, they use the heart score all the time. So this shows that there's misunderstandings that led to CODE-HF not being viewed in the same way that other ED decision aids are viewed. And here's a quote from a clinician researcher. Sometimes it's like the ED attending is the one who makes the final decision to admit. I don't think it really matters if the hospitalist or, and they mentioned cardiology attending, the fellows, know what CODE-HF is because it's up to the ED attendings. It's the ED attendings' job to say, hey, this person's sick. They have such and such needs. It's their job as a physician to build the story. So this shows that there were misunderstandings about the role of the tool in the ED process. ED physicians frequently brought up to us that hospitalists and cardiologists didn't ask for the CODE-HF score during the admission handoff, and they felt that this was evidence that the cardiologist didn't believe in the tool. But this quote describes that the CODE-HF tool and score are really to be used as decision aids for decision-making by ED physicians, and that they may not be as relevant or useful for admitting physicians in the way that it was implemented here. So the third theme is that there were technical challenges and errors in the usage reports, and this may have underestimated actual use and contributed to project dissatisfaction. Usage reports, as was mentioned before, were created not only for the ED physicians, but also for ED nursing staff as well. So this is a quote from a nurse administrator who said, but basically they're all over the place. I've had people be at 100%, I've had people be at 75 or 50, and then I've had a week where I got a whole report of 0. And that's when I started questioning myself. Like, this doesn't seem right. I don't feel like we're at 0% compliance with this. The fourth theme is that for patients who have multiple comorbidities or differential diagnoses, CODE-HF was perceived to have less utility and increased liability. So this is a quote from an ED physician champion, and this demonstrates the idea of less utility in that patient population. Some people were uncomfortable having a high-risk patient go home. They're like, now I've got this data point on their chart that says they might die this week, and I'm going to send them home. And that happens nearly every time you have a dialysis patient because their creatinine is so high, it increases the numbers on that score. And then this quote is from an ED physician who's describing a hypothetical situation, and I want to emphasize that this was a hypothetical situation. I'm sitting there defending a case to a trial attorney that I sent home a patient that then decompensated and died. I say, but my code heart failure score was 0.8, and it said that I was okay to send him home. And they said, but doctor, I don't know what the hell that thing is. You know, there's a couple of white papers on it, but did you not use your clinical acumen and decide that this patient needed to come into the hospital? And then here's a couple of shorter quotes from two different ED physicians. If you act against the score, you're going out on a limb and somewhere not supported by the evidence. And then if I'm sending them home and they have a high score, I take it off. If I don't agree, I take it off. And by take it off, it means take it off the EHR, delete the score. Theme 5 was that the absence of rapid feedback sessions with stakeholders led to decreased team engagement and information that would have facilitated project improvement. So this is a quote from a hospital administrator. The compliance data that we receive for enacting code heart failure and getting a risk score or initiating the order set, because for almost 2 years now, it's been 0%, 0%, 0%. And then you've got the providers on one end saying, we're doing this, we're doing this, we're doing this. How could it be 0%? And I think that this shows that there were challenges with Code HF that weren't addressed for a long period of time, and this decreased adoption and buy-in from the clinicians. So lastly, the sixth theme is that there was misalignment between departments in what constitutes appropriate quality of evidence for clinical implementation. So this is a quote from a quality improvement staff person. So you've got a lot of tension between different specialties and what they will accept as evidence-based or not. And here's another quote. And so you can sort of see some of the skepticism in this quote from an ED physician. I don't think it's even close to adequately validated to roll out the way we have AHA and other initiatives. And with that, I will turn it over to my colleague, Kate Verlaine, to talk about some of our conclusions, summary, and implications.
Thank you, Danielle. Okay, so Danielle went over a lot of stuff. And so here I've sort of distilled some of the barriers to adoption that we identified within the themes. So those include the unusual implementation path and the championship issue, where there was a lot of instability within the ED physician champions. The understanding of the tool as being another risk stratifying tool to assist and not replace clinical judgment. Technical challenges and errors that were frustrating to trust and relationships. Use case in the instances of multiple morbidities and complications, which goes hand in hand with liability concerns. And then users feeling heard and their concerns being rapidly addressed, and the theme of quality of evidence. So each of these came up, and then they're very interrelated, of course. So next steps. This is supposed to be dark like this. Yeah. Thank you. Okay, so what's next for our team is that we need to complete the thematic coding of these interviews and return to the interviewees to discuss our summary findings and make sure that they agree that we've understood them correctly. So that's number checking. Once we've done that, we will identify all the barriers that we can in the interviews and map them to known implementation strategies in a general sense, from which we can then develop project-specific strategies for addressing the barriers. So I'm going to give you an example from one of our identified themes. Theme 3, technical challenges and errors in usage reports may have underestimated actual use and contributed to project dissatisfaction. So our goal in addressing the barriers associated with the theme was, well, one of them, there's multiple goals, but one that we actually have resolved is addressing the errors in the usage report. So general potential implementation strategies that mapped well to this goal themes were to involve data experts and develop and implement tools for quality monitoring. So more specifically, the strategies we came up with and actually have implemented were to engage with the IT department to resolve inaccuracies in the usage reports. And with their help, we built a streamlined dashboard for on-demand real-time feedback for how the tool is being used. So that's a real slick tool that we're hoping the physicians will appreciate. So yeah, the next step after developing the specific strategies, of course, is to implement them with the help of the key stakeholders, making sure that they're on board all the way. So from a much higher level perspective, the implications of our work here are that as healthcare shifts from a volume-based to value-based reimbursement, the need for learning healthcare systems to more quickly uptake evidence into practice is critical. And novel quality improvement programs like CodeHF, paired with implementation science, have significant promise to help stakeholders in this transition. Thank you.
And I think we can turn it now to our next speaker.
So yes, that was phenomenal. I took a lot of notes and I look forward to discussing that. But Ken and Janik, you're starting to roll this out at KU and would love to hear your early experiences and thoughts.
Absolutely. And you'll start seeing some of the themes, the same themes come up again. Let's see, it looks like my video device is set up incorrectly. Hold on one second.
Yeah, I find it interesting as an ED physician, hearing the perspective that you guys had coming from kind of a more of a cardiology standpoint, and the viewpoint we're about to share from the ED looking the other way, and some of the shared commonality and struggles that we've had together on this.
Absolutely. So again, I'm Ken Marshall. I'm one of the ED clinicians at the University of Kansas and also the vice chair of clinical operations. And Janak is here with me.
Yep, and I'm one of the admin and operations fellows, which, you know, CodeHF plays very much into what we're trying to accomplish in terms of improving both ED operations and overall hospital operations as well. And Chris Pittenger, who is not able to be with us presenting this today, but she had a lot to contribute and want to recognize her work, and the rest of the heart failure committee who's also contributed to some of these efforts as well. So going back to the need of why this was implemented within our health system, very similar to what others have already covered, but as there's an increased focus on value-based payments in programs by CMS and other payers, heart failure is a really easy target because there's trackable metrics, trackable outcomes, and 30-day readmissions is becoming a major metric and will continue to do so in the future. And you'll see that many of these admissions and readmissions come through the ED, and so we're at a very unique place to have an impact on this metric directly. Although our payment in the ED is not directly tied to 30-day readmissions of heart failure patients, we are the pathway which these patients come in. And there's no established ED to heart failure clinic referral pathway that had already existed at KU, and there's no established criteria for safe discharges. And so you'd go into a scenario where people would use clinical gestalt, and that would obviously be okay in some situations, but probably admitted more patients than we probably needed to. And looking at some of the data on the next slide, we can see this is numbers from KU directly, and I'm sure it's very similar to other health systems across the board, but the number of admissions, primary heart failure diagnosis admissions and readmissions coming through the ED is about 60 to 70% on average. So a majority of these patients come through the ED rather than getting directly admitted.
And so this slide probably has been well enough covered by Dr. Spurtis and others today, but basically CODE-HF, the project to basically use a validated decision tool to assist our assessment in the ED of heart failure patients, and then to rapidly evaluate diuresis if necessary and discharge patients that are judged to be at some low threshold of risk, and then offer expedited follow-up to a heart failure team for the patients who are discharged from the emergency department. The implementation at KU, really began December and January of 2020, 2021. So right in the thick of the pandemic. There was an initiative requested by our heart failure team to take a look at this project. And we requested it, and then it was kind of triaged to informatics and HITS teams, and leads were assigned. Then we spent several months in preparatory meetings to develop workflows that would work for our particular context, benefiting a lot from the expertise of the teams at QVIC and St. Luke's, and what was known in the distant history as Truman Medical Center. And then the next phase was design and build meetings with multiple IT and informatics teams to take the workflows that we had developed between the ED and the ED nursing, ED physicians, and the heart failure clinic, and to translate that into usable EHR resources and workflows. This is a diagram of the workflow that just shows the general path of a patient arriving to the ED through their ED presentation and ED workup, and then triage to the heart failure clinic for a discharge patient. One of the questions that we were asked was, what were the meetings like? What was the intensity of effort required to get this set up? Obviously, we benefited tremendously from this being done at St. Luke's previously, so that we could benefit from their wisdom. But the preparatory phase of the work was about 10 one-hour meetings that had about 4 informatics and HITS team, 2 to 3 ED and cardiology physicians, 2 to 4 nurses and clinic managers, and then of course a rotating pool of experts from the QVIC. Then our design and build meetings was approximately another 10 meetings, each an hour long. A lot of more informaticists involved in those meetings. And then between the meetings, which were weekly, the informaticists and HITS team were doing lots of work in the background. And the physicians were usually given a token action item so that we could make ourselves feel like we were contributing in some tiny way. And then nurses and clinic managers were participating in those meetings as well. In terms of the champions, that was something that came up a lot in the last talk. I was the ED physician champion, and then, I should probably add in our chair, Chad Cannon, as well. And then we had a heart failure physician, Jane Titterington, who represented from cardiology. Our ED clinical nurse specialist, Chris Pittenger, was extremely helpful in workflows, and also building consensus around this from our ED nurses. And while they weren't champions in the conventional sense, I couldn't have a slide here without mentioning Angela Herman and Catherine Fuller, who are our informatics lead and our ASAP analyst, who helped really make the tools that made this work. I would say for a moment, especially after the previous talk, I think it was theme 2, which mentioned the importance of having something, at least with ED, that the ED physician team could believe in terms of the score itself and the rationale for using the score. We all know about readmissions, and we all know that it's important to keep people out of the hospital, heart failure patients in particular. I'd say for us, coming at this in the middle of the pandemic, one of Dr. Cannon and my primary focuses is to be delivering care that's system integrated. So, we don't view the ED as kind of an island, but really a part of the continuum of care between acute care and then post-acute and ambulatory care. That's one thing. And especially, dealing with a year and a half of capacity challenges from an ED that's too small for the hospital, plus the COVID challenge, plus staffing challenges, which every health system in ED is working on. We are firmly of the approach that the ED, we help ourselves by helping managing inpatient capacity. And so CODE-HF fit right along with a number of other initiatives that we took, that we were doing during the pandemic. Discharging patients with home oximeters and close follow-up by telehealth, making an urgent primary care referral pathway for patients that were at a threshold of being admitted if they could be seen in the next 48 hours, and a couple of other initiatives that are just along those exact same lines. So Code HF was fit right into what we see as one of our major emphases as operational leaders at University of Kansas. So in terms of the education, after we got the process built and we were about ready, both myself and Chris Pittenger, our nurse, gave 10-minute presentations to the ED faculty, our advanced practice provider group in the ED, and our residents. And then Chris also talked to the nursing groups. We did that initially in January, and around the same time, Dr. Titterington presented to cardiology faculty to make sure that there was buy-in on the project from the cardiology faculty generally, and especially the heart failure group. And of course, she was also talking to the ambulatory and clinic staff to make sure that they had capacity and things like that as we were building out the project. There were a couple of delays with respect to some of the IT builds that we needed. So our initial go live was in February of 2022, but it was delayed till May. And so as a result, the education we thought was probably getting a little bit stale. And so we revisited the education again in April by in-person presentations and also by email. The implementation, I won't linger too much on this as we already kind of know how it works, but the idea is that Epic generates at least in the way that we implemented it, Epic would try to generate as much of the score as possible. And we tried to use machine learning to see if Epic could generate the entire EHMRG score, but it wasn't able to do that. But what we were able to do is pull it in so that the physicians could review only one or two components, such as arrival by ambulance and whether or not they had active cancer, and then use those to finalize the score so that neither the nurse nor the physician had to waste time putting in the score components themselves. And then, the rest of it worked kind of as Dr. Spertus has already described. These are a couple of the screenshots of our particular implementation. I don't remember off the top of my head if these look exactly the same or substantially different from what St. Luke's did. Obviously, we had to keep in mind the exclusion criteria from the seminal studies on it. And then these are the few pieces: was the patient transported by EMS? Did they have active cancer? They take metolazone that the physician needs to enter in, having done that very difficult piece of doctoring, which is actually talking to the patient. And then you calculate the score. The score then gives you the probability of 7-day mortality, the raw score, and a qualitative risk estimate. And another thing that was important to us is to have the physicians, if the score yielded something that the physician didn't think seemed quite right, didn't pass the SNP test, that Epic will spit out the components that led into the score that was being used. Then if the score is high risk, it appears in the storyboard in red. If it's low risk, very low risk, it appears in green in the storyboard to help kind of be a visual cue for the physician. If I remember correctly, we stole this directly from St. Luke's. Another thing that we did was basically added a smart phrase to expedite the medical decision-making communication. So if a patient was high risk and was going to be admitted, according to Code HF, there was kind of a blurb that described the use of the score, the components that went into it, and the fact that the decision was made to admit the patient. And similarly, some explanatory language if the score was low, what went into the score, and that the patient was diuresed and discharged. And then the Code HF discretion gives the physician the option that even if they calculated the score, if for some reason their gestalt was that the patient shouldn't be admitted or discharged, depending on what the score said, it kind of explained their decision making. This is good not only just for a general practice of communicating in the chart, but it also, particularly as coding and billing changes effective in January 2023, this kind of complexity and thought that goes into it will be very helpful for billing. Finally, there is a picture here of the appointment request. As you can see, we have a lot of different follow-up appointment requests to the ED, given our previous emphases that we described, but one of them that was added as a result of this was a expedited appointment request from the ED to our heart failure clinic. And for any patient that was selected for discharge, they would have heart failure education automatically plopped into their after visit summary. So the reception, I think this is Janex.
Yeah. So, for us as an ED, we've taken the approach that we want to be on the front lines of innovation, and we frequently adopt a lot of changes as making sure the patient is at the forefront. So a lot of those post-ED follow-up are a result of having that mindset. So as an academic ED, we have the unique experience that most of the patients receive their care from a resident before an attending. And because we so often implement some of these changes in clinical pathways, it was pretty easy to get this implemented in terms of rolling out the education and getting providers to buy in. We received very little pushback from the ED providers about getting this done. Now, I will say had a very similar issue, as did our St. Luke's colleagues. However, it's kind of in the inverse that as we were rolling this out, unfortunately, there's some turnover in our cardiology colleagues that were spearheading this within their own department. And so that led to a couple of roadblocks and some issues that we had to work through going forward.
Yeah, I would say one other thing that I would add is not only do we have the hiccup where we had a changeover in champions, but this relates back to theme 3, I want to say. Getting my themes mixed up from the previous talk, but we definitely had the experience of discussing the score with some of our cardiology colleagues, and our impression was this had been fully vetted with cardiology. The cardiology department was embracing this with both arms. And then we had providers reach out and discuss patients with cardiologists for one reason or another. And we were saying things like, we were planning on sending this patient home, their EHMRG score is X or Y. And the cardiologist would say, what score is that now? And are you sure you want to send this patient home? That seems bad. So it only takes 1 or 2 episodes like that to get an ED physician group to be extremely leery about an intervention. And another one of the themes that was mentioned was whether or not the ED is willing to utilize decision tools. I'd say we've proven again and again that we are, both as a specialty and especially at KU. But the heart score versus the EHMRG is really not a good comparison. If you take someone that's low risk by the heart score, that gives them approximately a 2% or less risk of major adverse cardiovascular events, which is a composite endpoint, right? That includes some things that are probably not all that important clinically to a patient, like revascularization, and that's over 6 weeks. That's a huge difference from a 1% mortality threshold over 7 days. And so I have a lot of sympathy with our own physicians who are a little leery of using this initiative and want to know that it's something that's endorsed fully by the cardiology group that's practicing and that it really is standard of care. So I think that's not necessarily a confusion among ED providers. I think that's something that when you deal with implementation, the devil is in the details.
Exactly. And now, we just got the data in the report built out on this, and obviously that takes some amount of time. So we were just able to look into it very briefly as we got it this week. And you'll see when we go through this that the implementation started off strong. And then as we kind of lost a little bit of confidence going forward, and we didn't have the data to go back to providers and show them what was going on, we just stopped more or less using the score. So I just pulled the data from July 1 up until this October, looking at the new academic year. And overall, there were 12 patients that had an EHMRG score calculated. Of that, 10 of them were in July, 2 in August, and then subsequently no more scores were calculated. So I think that really reiterates the need for ongoing provider education and re-engaging our cardiology colleagues and focusing back and trying to figure out what we can do to get this going again. Of the 12 patients that had a score calculated, 6 were ultimately discharged from the ED. On average, those patients had a 0.44 7-day predicted mortality risk that was calculated. And looking at the follow-up, 3 of them did have follow-up appointments completed. 1 of them was scheduled but not completed yet. And as you can tell that if the last patient that had a score calculated was in August, this follow-up was, although scheduled, not completed within the 72-hour turnaround time that would be ideal. 1 of the patients had canceled and 1 of them no-showed. So at least we can see that the other 2 people ended up having an appointment scheduled, but then chose not to go. Of the 6 patients that were admitted, they had a little bit of a higher 7-day predicted mortality, about double than what it was. But when you look at why they were admitted, sometimes there was other coinciding factors, such as 1 patient had concurrent cellulitis. A couple of them were admitted for acute coronary syndrome type process and ultimately received a heart cath, but 3 of them were primary heart failure diagnoses, of which 1 had an intermediate risk. And so we would have to go back and look deeper and to see why they were ultimately admitted and maybe if we had that data in a real-time manner, we could go back and talk to the provider and see if they just weren't comfortable with the score, if their gestalt felt different, or if there was other coinciding factors such as social situations, which may not be easily identifiable just on data report. And so looking forward to the future, certainly we need to now do continued education with their new data. And I really love the fact that at St. Luke's, they pulled the data for each individual provider and had that available to share. And we'll continue to identify and readdress any roadblocks going forward. And certainly, I think we know what they are at this moment, and we have some work to do on our end. We also look to publish some results once we have more data to existing literature to help other departments across the US and around the country, around North America, I suppose, try and implement this in their own departments as well. And hopefully we can implement further heart failure pathways from the ED to further reduce readmissions. CODE-HF is certainly a great start, but certainly there's other pathways that may be appropriate as well that we haven't addressed at this minute. So with that, we'll go ahead and open it up for questions. I'm not sure if there's questions specifically for us or for everybody, or if there's anybody speaking after us. So.
No, you guys are the final closer for this. Do you think the data that Doug provided will be helpful in going back and re-engaging both cardiology and the ER docs?
Yeah, it's a great question. I mean, I think a lot of our physicians are data driven, and having that would be helpful. So if there's a way we could get some of those slides, if you wouldn't mind sharing, we'd love to take that back to our group and maybe share with our cardiology colleagues as well, and re-engage in what the standard would be at our institution.
Yeah, and we did share, of course, the original papers that have been published prior already, and you know, so we knew going in that a big part of this was going to be about assuaging our docs, in addition to making the case why it's useful, assuaging them that it's, you know, safe, and that we, especially that the follow-up pathway worked, so that they could know that they weren't sending patients off into kind of the ether.
Yeah, we'll get you the paper from the New England Journal. Doug, I see you have your hand raised, and one question just for you to also address is, you used a slightly different eMERGE score than we used, and do you think that there's something wrong with our current logic? Do you think, you know, yours even seemed a little bit more complicated? We sort of thought we followed the KISS principle, right? I mean, less than 1% consider discharge, over 1% just, you know, warrants bringing them in. Yours had 3 levels and just more complexity. And in trying to make it really, you know, straightforward and simple, do you think we're going astray by not using the 730 score, or you think the 7-day score is actually reasonable in this setting?
Yeah, thanks, John. So first of all, you know, really impressive work. I think you know, everyone's presentations really fabulous. I think you guys are the you know, definitely one of the leaders in implementation here. So fantastic. I learned a lot. You know, I think the 730 score is potentially better, John, because you know, some of the patients who are low risk at 7 days, you know, do have an event that could have a day event, you know, within 30 days. And so we kind of look at that, we expand out to 30 days. As well as 7 days, and so, you know, we're pretty confident that the low risk patients are pretty low risk. We actually looked at the data on safety and found that there were 0 deaths in the low risk patients before they could be seen by a physician, in the low risk group and in the intermediate risk group. And you know, there were less than you know, sorry, in the low risk group up to 30 days before they're seen by a physician, 0 deaths, less than 6 deaths out of, sorry, less than 6 events in all of the intermediate risk patients before they were seen by a physician within 30 days. So, you know, it's pretty, they're pretty, it's a pretty, they're pretty, the signal is that there's very low rates of, very low rates of events, especially in the low risk patients. So I think the 30-day score, you know, is better. But, you know, kudos to you guys that you were able to implement, you know, get it into Epic. Because we're trying to do that now, and we'd love to compare notes and see how you guys managed it. Because we just started with Epic, and so we're kind of on that love-hate relationship with Epic right now. Phase. So it'd be great to kind of compare notes. But you know, I think the 730 score is probably the way to go.
So two things. First of all, you know, one of the things I love about this collaboration in Kansas City is that, you know, St. Luke's and KU compete viciously for patients and for prestige, but in this avenue, you know, St. Luke's spent $90,000 in a year building the score, and they gave it to KU for free. You know, not that KU didn't improve it and do their own stuff, but there was a real collaboration that was very nice. And by extension, I think we'd be glad to give you our code at Epic if that would help your group. You know, when I looked at your graph of the 70, the 730 score, there were very few patients that had a 7-day score that were in that intermediate group. That's 30-day score was that high. And if you only had 6 deaths in that entire group, I mean, I wonder if using the 7-day score alone, you know, all we would have done is not classify some of the intermediate risk patients as intermediate risk, right? And so at some point we can do this offline, because I want to be confident we're doing the best score. And because we've already programmed the 7-day, I'm sort of inclined to stick with it unless it's just not the best, you know? And so perhaps we can meet offline and just dig in a little deeper if we should switch scores or not, in which case you can build the score and give us the code. So
yeah. We'd be happy to share. You know, so our results are shown visually. So what happens is, well, the way it was programmed in the trial was that there would be a plot, and then you would see where that patient was on that plot. So it wasn't a number, which can sometimes be cold and a little bit, you know, hard to interpret. So you can, if you see where your patient lies on that graph, it might help you, because if they're kind of straddling that low intermediate, you know, then it might, you know, it might make a difference than if they're low, truly in that solid low zone. So you know, so you know, it'd be interesting to see how people perceive using the 30-day, the 7 and 30 compared to the 7.
Kate
Hey,
had a
John?
question. I don't know if Kate, if you want to ask.
Sorry, not really. I apologize if you already covered this, but I was wondering, since a lot of your patients went on into like in-hospital observation period, did you do any analysis of outcomes on just the subgroup that were discharged directly from the ED, which is kind of more comparable to how we've been using it?
Yeah, so that was part of the review process, and so the results were very consistent. You know, we don't want to make conclusions, but you know, there was a statistical benefit in those who were low risk. So you know, but that's a subgroup of a subgroup. So, but it was pretty consistent with the overall trial results.
Doug, how often was the score actually run in the ED as opposed to the inpatient setting?
We don't know how often it was run. I mean, like, you guys have really you know, kind of, you know, really been very solid in terms of measuring it. We don't know how often it was run. You know, we do know, you know, on the patients who the patients who were referred to the rapid clinic, they definitely had to have the score done. So, about a third of the patients had the score done because they were referred to rapid. So there was probably more than that, but we don't know the exact number.
Hey,
But the Epic integration and the integration into the EHR is, I think, really, really important. So you guys are like a real step ahead. Fantastic.
Somebody from 913 has a question, and please speak up.
Hey, John, can you hear me okay?
Yeah, sure can.
Hey, John, this is Tony Sun here. I just want to make sure you guys knew I was on the phone, but I really want to applaud the work, all three, in regards to how CoHF is now being placed in particularly in the two academic centers here in Kansas City. And then thank you so much, Doug, for being here to share your study. I think we need to further this work, and I have been a big fan of cohort failure and how else we can make the handoff, the transition of care better. I think it's going to be critically important. I think what I heard is that we can get the implementation more refined and more education. And there was lots of lessons learned in the human factor of that, in particular in physician champion turnovers and cardiologists. But if we can do more to get more wider implementation and get more members scores run, in particular through Epic, that would be great. The other thing I will let you know is I'm on the steering group of the Epipair platform for United Healthcare, United Health Group. So they're listening to us quite a bit. So if I can be of help there, please let me know.
Well, it would be a huge help. And I don't, I mean, obviously, I hate to say this out loud, but, if there was a way that there could be, like any other diagnostic test, some payment for running this, boy, would we get adoption up fast, But I think for you to share, I mean, it's a huge savings to United to not have those patients admitted. And so,
but we've got to be very careful about how we do that. And I can't talk about that because how we incentivize for not admitting a patient and influencing that. But in both institutions, I can say this without getting myself into trouble, there are plenty of value-based contract incentive already in place. Okay, I can say that very out loud.
Great. Well, I just can't thank you guys enough. I mean, this is really exciting. It's hard work. A lot of people have put a lot of time and effort into it. It's a long road. I mean, it just seems like it'd be so simple to turn something like this on, but it is very challenging. And to be able to work with colleagues at KU, with the qualitative team, with our own PD, to have payers involved, and Doug, for you to spend your afternoon with us sharing what you've done. And I think the data you provided will be very, very helpful in us creating more support for this going forward, as being a very patient-centered way to handle a very complex triage decision. So thank you very, very much. If there are any other questions, please speak up. Otherwise, I wish everybody a really nice Thanksgiving, and thank you so much for participating today.